Hi, welcome to this short demonstration video on shoulder dystocia for PST5107 Advanced Obstetrics. Now, shoulder dystocia is relatively rare, although it does affect between 0.6 and 1.4% of vaginal births. Shoulder dystocia occurs when the fetal head has been delivered and the fetal shoulders actually fail to deliver and therefore block complete delivery of the fetus. Now, the reason for this entrapment occurs with either one or both of the fetal shoulders are actually impacted against the maternal pelvic bones. It can result in serious complications for both the mother and the newborn without proper management. In the pre-hospital field, we often have very limited resources and time, and we rarely have an obstetrician or a midwife at hand, so it's really important for us to be able to manage this confidently and efficiently. It's especially important in remote area health where we have an even greater lack of resources. In this video, I'm going to talk about each of the maneuvers that we can apply as paramedics. Just note that some of the maneuvers may not be integrated with some ambulance services. However, I'll still apply them according to best practice. The maneuvers I'm going to be talking about and demonstrating are the McRoberts, the reverse McRoberts, how to apply suprapubic pressure, the Reuben, the rocking Reuben, the wood screw, reverse wood screw, and then finally I'll talk about the posterior arm removal. Alright, so this is the McRoberts maneuver. So what you do is you just move the maternal legs up onto the abdomen. Alright, so applying the McRoberts maneuver, so here's our pelvis and here's our baby, and that's the shoulder dystocia there. When you apply the McRoberts maneuver, you get cephalad rotation of symphysis pubis, and you actually get a flattening out of the sacrum, which would create a bigger gap. Because in all these maneuvers, what we're doing is we're trying to get a bigger birthing canal so we can pull the baby out. So that would be the delivery of the baby. It's actually been shown in just applying the McRoberts maneuver alone that 42% of cases can be resolved with just this maneuver. The reverse McRoberts is when you place the mother on all fours. You just roll her over, place her on all fours, and it's actually very effective in very minor cases of shoulder dystocia, as the movement alone, just the rotation, can actually dislodge the fetal shoulder. Alright, so the next maneuver I'm going to demonstrate is how to apply suprapubic pressure. So that's our pelvis, that's our shoulder dystocia. As we can see from the side there, that's the anterior shoulder. The way you apply suprapubic pressure is just above the pubic symphysis. One of the clinicians applies pressure there. Obviously, this is not to scale. Now, the goal of this is to hopefully achieve a rotation with the pressure, so the baby rotates and you're able to get the baby out. Okay, so this next maneuver is called the Reuben maneuver. Now, the Reuben maneuver, obviously this is not to scale, can be applied with the suprapubic pressure, but basically what happens is that one of the clinicians places their fingers on the posterior aspect of the anterior shoulder. There's our anterior shoulder, that's the posterior aspect, and they actually press pressure to try and rotate the baby. And what this does is it places the baby in an oblique, the shoulders in an oblique angle, and it gives you approximately 20 mils more clearance so you can birth the baby. Also, if this doesn't work, we can apply suprapubic pressure with one clinician, then the Reuben maneuver, as I'm demonstrating here, and you can actually use a rocking Reuben. So that's a rocking motion with both clinicians gently rock to try and get that oblique placement of the baby's shoulders and give you that much more clearance and birth the baby. Okay, so moving on, this is the wood screw maneuver. So the wood screw maneuver is an extension to the Reuben maneuver, and so you've got the posterior pressure on that anterior shoulder, and what happens in the wood screw maneuver is the clinician actually places their other two fingers on the anterior aspect of the posterior shoulder, and you attempt to rotate. So you attempt to rotate once again, trying to get that clearance of 20 mils so you can birth the baby. So there's the wood screw and there's the reverse wood screw, depending on the presentation. So that would be a counterclockwise rotation. If the presentation of the baby was this way, you would apply in the reverse fashion. So you'd apply pressure again on the posterior aspect of the anterior shoulder and on the anterior aspect of the posterior shoulder, attempting to get that rotation. So that gives you that oblique position of the baby to be able to birth the baby. Okay, so the next and the last maneuver I want to talk about is the posterior removal of the fetus. So with the posterior removal of the fetus, this is the last technique that should be applied after all the other simpler ones haven't been successful, just because it's way more invasive. So basically with the posterior arm removal, what we're going to do is we're going to remove the posterior arm, and this usually almost always results in the delivery of the trunk and thus the delivery of the baby. So what happens is that the clinician would actually insert one hand into the vagina and try to palpate for the posterior elbow and grasp the baby on the forearm. So if I demonstrate on me, the movement that you'd apply is you would move the posterior arm across the fetal face and up and out, and that would actually birth the baby. This concludes our short demonstration video. Thank you very much.